ahead and get started. Welcome to the North Carolina AHRQ Practice Support webinar on integrating behavioral health and primary care. My name is Liz Griffin, and I'm a licensed clinical social worker and quality improvement and practice support consultant with Greensboro AHRQ. This webinar is part of the monthly North Carolina AHRQ Practice Support Services Lunch and Learn webinar series. These webinars are held the last Wednesday of every month from noon to 12:30. A quick reminder for everyone to please make sure that you are muted. I don't hear any feedback, so I think we're good on that so far. There will be some time at the end of today's webinar for questions and comments, or you can type them in the chat. Today's webinar will address the importance of integrating behavioral health and primary care, common questions about behavioral health integration, evidence-based models of integrated care, especially the collaborative care model, and resources for primary care practices interested in integrating behavioral health. Before we officially get started, I'd like to state the disclaimer that behavioral health integration in primary care is a broad topic, and day-long lectures and multi-day conferences are dedicated to this topic. That being said, I realize that our 30-minute webinar today will only scratch the surface. I plan to devote time at the end, like I said, for your questions and your feedback. This infographic from the Eugene S. Farley Jr. Health Policy Center at the University of Colorado highlights the case for integrating behavioral health and primary care. The Farley Center's mission is to make health whole by developing and translating evidence into policy to advance comprehensive, integrated strategies that improve individual, family, and population health. The statistics stating that 46% of adults will experience mental health illness or a substance abuse disorder at some point in their lifetime, and that 66% of primary care providers report they're unable to connect patients with outpatient behavioral health providers, indicate a strong need for integrated care. Additional research and evidence shows that behavioral health issues such as depression significantly worsen outcomes for many chronic diseases when left untreated or undertreated. Studies have also shown that patients who have access to integrated behavioral health care show significant improvements in control of high blood pressure, hemoglobin A1C levels, chronic pain, and overall cost of care. Research has also indicated that only 20% of patients will have seen a behavioral health provider a month before their death from suicide. However, 80% will have seen their primary care provider. There are several questions surrounding integrating behavioral health and primary care. Most questions fall into these categories. What are the major components of integrated behavioral health and primary care? What interventions and screening tools are used in integrated behavioral health care? Are there evidence-based models of integration? What are team member roles and responsibilities? What are the benefits? And lastly, what are some resources for practices trying to integrate behavioral health in primary care? This table highlights the overarching components of behavioral health integration in primary care. The main component is having a healthcare team that consists of one or more behavioral health providers, either a counselor, social worker, or psychologist, and includes all members of the primary care team and the patient. The team should also include a consulting psychiatrist to provide access to psychiatric recommendations and medication management. All team members should be trained in behavioral health care procedures. The practice should also provide immediate access to the behavioral health care providers and registry validated or universal screenings for identification and treatment of health issues. Screening for mental health, substance abuse, and health behavior issues and provider decision support should be seamlessly integrated into patient flow. Models for effective integrated behavioral health care are comprised of key principles. The patient-centered team members collaborate. Co-location is not necessarily collaboration. Patients are tracked in a registry to ensure population-based care and no one falls through the cracks. Treatment is measurement-based to target and is actively changed until clinical goals are achieved. There should also be a shared, transparent EHR with two-way notes and access to information. Treatments provided are evidence-based and providers are accountable and reimbursed for quality of care, not volume-based care. This is a list of integrated interventions that can be provided by a behavioral health care provider in a primary care setting. Several of these interventions are often provided by primary care providers, but frequently are cut short due to time restraints. Behavioral health integration provides more opportunities for education and interventions related to health promotion and prevention, self-management skills, motivational interviewing, assessment after positive screens, family conflict resolution, solution-focused strategies, psychoeducation, and positive coping skills. Here is a list of registry metrics and screening tools that are frequently used in integrated primary care settings for children and adolescents. The registry metrics for behavioral health for children ages 0 through 12 include ADHD, anxiety, bipolar disorder, depression, obsessive-compulsive disorder, oppositional defiant disorder, personality disorders, and wellness metrics. The registry metrics for behavioral health for adolescents ages 13 to 21 include opioid dependence, tobacco and alcohol use, chlamydia and gonorrhea screening, HIV screening, and wellness metrics. Some standard screening tools for behavioral health are also listed. The American Academy of Pediatrics also has a great resource for mental health screening and assessment tools for primary care. I've included the link here, and it's listed in the resources at the end of this presentation. The AAP toolkit includes various psychosocial measures, a brief description of each measure, projected administration and scoring time, cultural considerations, and info about cost and developers of the different measures. The Agency for Healthcare Research and Quality, or AHRQ, has established the Academy for Integrating Behavioral Health in Primary Care. One of the resources made available to practices in the process of integrating behavioral health is the Integrated Behavioral Healthcare, or IBHC, Measures Atlas. I've included the link to it here. This atlas includes literature reviews and links to clinical measurement tools for anxiety, depression, physical health conditions such as arthritis, diabetes, high blood pressure. It also includes the Multidimensional Health Assessment Questionnaire, or MDHAQ, and substance use abuse measurement tools as well. Integrated care meets all of a patient's health needs in one setting. It can be delivered in multiple ways depending on who is providing the care, what type of care is being provided, where the care is taking place, and how services are being coordinated. There are different levels of services integration. The Substance Abuse and Mental Health Service Administration, or SAMHSA, designed a framework to help healthcare providers plan and support an integrated system. That framework has three main categories: coordinated care, which concentrates on communication; co-located care, which focuses on physical proximity; and integrated care, which emphasizes practice change. Within each category, there are varying degrees of collaboration between care providers. These levels range from minimal to full integration. Minimal integration is when medical and mental health providers work in separate facilities, have separate systems, and rarely communicate. Full integration involves a single health system's medical and mental health care providers working simultaneously to treat a patient's behavioral and medical needs with shared medical record access. A few examples of full integration care programs are the collaborative care model, and there's embedded and virtual integration within the collaborative care model. This is the most common model of integration used by primary care practices, and we'll take a deeper dive into this model momentarily. This model is also sometimes referred to as the Behavioral Health Integration Program, or BHIP. Patient-centered medical home, or PCMH, involves coordinating a patient's overall healthcare needs at any age. Patients play active roles in their healthcare. Providers coordinate all aspects of preventative, acute, and chronic needs of patients using the best available evidence and appropriate technology. Hub-based systems are found mostly in the child mental health world, and they're modeled on the Massachusetts Child Psychiatry Access Project and provide primary care providers with immediate telephone consultations with a child psychiatrist. Case management and face-to-face evaluations are also available for complicated cases. The 4-quadrant clinical integration model describes integration levels in terms of primary care and behavioral health care complexity and risk. The location, types of providers, and services vary depending on the complexity of patients' conditions. SAMHSA has also developed the Primary and Behavioral Healthcare Integration Program, which provides support to communities to coordinate and integrate primary care services into publicly funded community-based behavioral health settings. Let's take a closer look at the collaborative care model. It was originally developed at the University of Washington's Advancing Integrated Mental Health Solutions, or AIMS, Center. It's been established as an evidence-based method to address mental health in primary care settings by managing mental disorders as a chronic disease rather than treating acute symptoms. A team-based collaborative care program adds 2 new types of services to usual primary care: behavioral health care management and consultations with a mental health specialist. The behavioral health care manager becomes part of the patient's treatment team and helps the primary care provider evaluate the patient's mental health. If the patient receives a diagnosis of a mental health disorder and wants treatment, the care manager, primary care provider, and patient work together to develop a treatment plan. This plan may include medication, psychotherapy, or other appropriate options. Later, the care manager reaches out to see if the patient likes the plan, is following the plan, and if the plan is working or if changes are needed. The care manager and the primary care provider also regularly review the patient's status and care plan with a mental health specialist, like a psychiatrist or psychiatric nurse, to be sure the patient is getting the best treatment options and improving. I've included a link to the AIMS Center if you'd like to learn more about the history of the collaborative care model. They also have wonderful additional resources related to the collaborative care model. This flowchart provides another visual representation of the collaborative care model. The specific processes to note are the direct communication between the primary care provider, the patient, and the behavioral health care manager, and the communication with the consulting psychiatrist. This graphic also includes optional community behavioral health resources such as substance treatment, vocational rehab, and clinical or community mental health counseling. Collaborative care includes both embedded and virtual integration. Embedded integration includes at least one behavioral health care manager and a consulting psychiatrist within the practice. There is a clinician available for personal face-to-face introductions or warm handoffs and consultation between the primary care provider and the behavioral health care manager. The team meets weekly for treatment meetings. Virtual integration for collaborative care includes monitoring of patients by the behavioral health care manager for positive PHQ-9 depression inventory scores of greater than 10 and/or an elevated generalized anxiety disorder, or GAD, 7 score. The primary care provider can initiate the referral and the patient is seen via video or over the phone. The team also meets for weekly treatment meetings in the virtual integration model of collaborative care. Virtual behavioral health bridges the gap for communities with limited resources, increases access to care, and reduces the cost of care. The roles and responsibilities for a behavioral health care manager on an integrated team are to work with patients and their families to improve habits, behaviors, and emotions that are impacting the patient's health or functioning. The behavioral health care manager should also work with the team to assist the patient and family to be successful at targeting specific care goals or problems. The behavioral health care manager should also educate and empower the patient's family, and the care team through provision of appropriate clinical interventions. The roles and responsibilities for the psychiatrist on an integrated team are to review complex cases weekly, provide consultation for medication management, provide ongoing supervision for psychiatric concerns, and regularly review the registry to improve medication compliance and outcomes. SAMHSA has this handy-dandy quick start guide to behavioral health integration that might be useful. I've provided the link here and a screenshot of the flowchart tool that the Quick Start Guide walks the user through to access readiness for behavioral health integration in a primary care setting. Throughout the tool, the user answers questions about his or her practice and moves through the suggested resources and next steps. I've included a few of the questions on this slide that the user would see when they move through this tool. Another helpful resource is the AHRQ's integration playbook through the Academy for Integrating Behavioral Health in Primary Care. The integration playbook is an online interactive guide intended for practices at all levels of integrating behavioral health into their setting. Before using the playbook, you can complete the self-assessment checklist. The checklist will show where your organization stands with respect to 11 aspects of integration and help you identify areas of focus and priority. You can complete the checklist online, or you can download the printable PDF version for team use. The content areas of the playbook have sections about defining your vision and making a game plan, how to implement the plan, including sections on preparing the infrastructure, establishing protocols and clinical workflows, and tracking and monitoring patients. The integration playbook also provides a North Star goal that reflects ideal practices of an integrated setting, such as the Cherokee Health Systems in Tennessee, for example, with respect to that aspect of integration and what resources relate to how you could do that in your own practice. The playbook also includes what not to do bullets, presenting pitfalls and obstacles to avoid while integrating behavioral health in your own practice. You can register for a free account at the website listed on this slide. A few benefits of integrated behavioral health in primary care include decreased costly crisis management and work absences, increased access to and completion of behavioral health referrals, increased patient and provider satisfaction, increased availability of medical providers for visits, phone calls, and documentation, lower costs for brief interventions provided over shorter episodes of care, and reimbursement for care coordination, therapeutic interventions and screening, and assessment tools. Behavioral health integration in primary care is also a high-weighted improvement activity for CMS's merit-based incentive payment system. And I know that slide's a little blurry, but that's the section where it qualifies as a high-weighted improvement activity. With every good measure, there's always some challenges, but also some opportunities. And that's the same case for behavioral health integration in primary care. Some challenges include education on behavioral health for the entire care team and setting clear roles and responsibilities of care team members, normalizing team access to the behavioral health treatment note. This may be the first time that your team has reviewed a behavioral health treatment note, developing standards of work around documentation, and data entry for screening and assessment tools, as well as knowledge of CPT billing codes that are reimbursable for integrated collaborative care. The North Carolina Psychiatric Association has helpful information on their website related to the collaborative care CPT codes. I listed them here, specifically their 99492, 99493, and 99494. They also have helpful information about their work through the Transforming Clinical Practice Initiative with CMS. I've thrown a lot of information at you, but I did want to provide a lot of the resources where I found some of these helpful guides. So those are listed here, a lot of the websites, and then some additional resources that I use for statistical information. Here is my email address if anyone has questions or comments after today's webinar. Also, I love this quote by Henry Ford that says, "Coming together is a beginning, keeping together is progress, and working together is success." I know we moved through all of that information rather quickly, but I did want to make sure that we save some time for some questions, comments, or conversation. Does anyone have any questions at this time? Don't all speak at once.
Hey Liz, this is Suzanne.
Hi, Suzanne.
What do you think, or there's it's kind of hard to find staff to fill these roles, even if a clinic wanted to do it. Is there any kind of pipeline programs in the state or areas that people can look to find qualified staff?
So several of the Masters of Social Work programs around the state do have either classes or tracks that are specific to integrated behavioral health. UNC Chapel Hill does have a program that's actually specifically focused a full year on providing social workers in primary care settings so that they kind of know what to expect for integrated care. So that there are some programs out there. I can also provide more resources on that if other people are interested. Did that answer your question?
Yeah. You don't know by chance what a starting salary for an LCSW would be?
I mean, typically it's probably 40 to 50, somewhere in that range.
Okay, thank you.
That would be my most educated guess on that. I just saw a question pop up in the chat. How do you get paid for embedded behavioral specialist? How do you get paid? Does that mean how does the practice? I'm confused a little bit by that question. How is the practice paid, or how would they pay?
How does the practice get? Everybody that's a member of the team and that is on your staff has to get paid. So the behavior specialist that's there, how, for my provider and those folks on that team, they submit claims and we get paid.
Oh, so I see what you're saying.
How do I recoup my money from this behavior specialist?
Sure. Does anyone on the call have any helpful ideas on that?
If I can't pay for them, I can't have them.
Sure, that makes sense. I think it would be what your practice could take on in terms of additional staff, because you would have to have at least that behavioral health care manager on your staff. And then there's probably consulting fees for the psychiatrist if they're not directly on your staff.
So I'm just brainstorming or thinking out loud with this. Is to take on a staff, it's looking at those 99 codes and all that, and looking at who are qualified providers for those charges, and then being able to bill out that way. If you're in a primary care setting, you could also use the LCSW to cover their for the transition of care or the chronic care management. Potentially, you could have them work on those types of billing endeavors that would help recoup some of the costs, or annual wellness visits. But it's really doing a deep dive in the billing codes of the behavioral health, activities or services that would help recoup the cost, is what I think. Anyone else have a different thought?
I have a question. This is Debbie, along the same lines. What would be you're going to need to recoup some of the costs, obviously, through billing or chronic care management, but what is the right mix of like one social worker to 3 primary care providers, or what's a good ratio? Does anybody know?
So I do know that the SAMHSA workflow, that is one of the questions that it asks, is about size of practice. And I think it has recommendations for how many providers to how many patients.
Okay, great. Thank you.
If anyone has specific ideas on that, please shout out. That's the purpose of this. So information sharing is always helpful. And Meryl, I just saw your comment in the chat about some practices show cost savings and having a behavioral health care manager. by saving money in the emergency department. It's a good example. And yes, a copy of the presentation will be available after the end of this webinar.
I have a question. This is Danielle. If you were to have, let's say, a psychiatric mental health nurse practitioner in the office, would you be able to perhaps save some of the money for having a consulting psychiatrist if the supervising MD for the practice was agreeable?
I mean, it's really, the model really recommends having that psychiatrist. I could see a potential for that, though. Anyone have other feedback on that?
Hi, this is Catherine. In our practice, we have a psychiatric nurse practitioner who's embedded, works for the organization, and according to the AIMS job description for the psychiatric consultant, it can be a nurse practitioner.
Great. Oh, great.
Hi, everyone. This is Meryl Canfer. I'm from the UNC School of Social Work, and I'm the coordinator of the program that was mentioned a little while ago. And our program is a HRSA-funded grant training students to work specifically in integrated healthcare. And we also partner with the Psych NP program here. So we're actually training social workers and psych nurse practitioners together in the models that, so Liz just did such a nice job outlining today. And everything that everyone has said in terms of salaries is right on. I think in some ways we're the cart ahead of the wheel. We've got a lot of students trained since 2014, but the number of practices that are locally ready to hire them is, sort of fewer than the number of students trained to do it. But we're ahead of the game, so we're glad. And there's great other schools in the area are doing this. UNCG has a similar program, NC State, ECU. We're not the only school of social work in the state doing this work and training students.
That is great. Thank you so much for sharing that.
Is anyone on the call, is their clinic doing integrated, or what model are you using, like the co-location or integrated? And if you are doing integrated, what are some of your lessons you've learned? It sounds like we all are just beginning.
Yeah, maybe more on that later as everybody, that'll be another webinar topic a few months down the road, maybe. We have time maybe for one more question or one more comment.
What would be a good first step if your clinic was serious about this?
I would really recommend using one of these tools, either the SAMHSA guide or the AHRQ, just to really assess, your clinic's readiness for all the different components that are involved. Don't walk through it blindly. Use what's out there, because there are multifacets to it, and you wouldn't want to miss an important component.
And use us, your AHRQ consultants, as a service.
Yes, good plug.
It's also really important to have everybody on the team educated in this different model of practice, just because, like one of the slides said before, it's kind of a practice change. So it's different than how providers and behavioral health care managers and the psychiatrists are used to working. So it's really important to make sure that everybody understands that and is agreeable to the change.
Definitely. That's a really important point. It's a big shift. Well, I want to thank you all for your time, your questions, your comments today. A link will be sent with a survey within the next few days from Southeast AHRQ. Your feedback is valuable to us, and Southeast AHEC will also send instructions about accessing the slides for today's presentation. Please note that continuing education credit was not offered for today's webinar. And if you don't already follow North Carolina AHEC Practice Support, you can look us up on Facebook or Twitter. Let's see, we'll throw that up here. That's at the end. Or you can check out our webpage at ncahec.net. Thank you all again for your participation, and I hope everyone has a wonderful afternoon.
Thank
you, Liz.
Thank you.